For those that don't know me, I'm Claire Hogg and I work at the Royal Brompton. I'm the lead for the National PCD Diagnostic Service here in London. And so Andy Bush, as you know, who's been sort of establishing this program with Nicola, asked me if I could give a talk about primary ciliary dyskinesia. And I thought it would be useful to sort of head it up with who needs testing, because it makes you, I think someone's got their, if everyone could mute their mic so that we get rid of the background sort of interference noise. Could everybody please just mute? That would be great, thanks. So I thought it would be really useful just to sort of work this around who needs testing, so that clinicians who are seeing patients who might have this condition are thinking about the cardinal signs, if you like, or aspects of the history that would make you think, is this primary ciliary dyskinesia, and how do I go about referring, where do I send these patients, and what happens once they've been referred. So with that in mind, see if I can get it to click on. Hopefully that's moving forward for you. A little bit about the terminology. I'll probably talk about primary ciliary dyskinesia, or PCD, in this talk, but in fact it's just one of a wider group of respiratory ciliopathies, if you like. It's the one we understand most. It's the one where we've sort of not cracked the diagnosis, but we have a lot of experience in looking at the function and structure of cilia. But it is just one of a wider group. And I think that's quite important to understand, because you'll see that the terminology is beginning to change in the literature. And you can see, for instance, here, reduced generation of multiple motile cilia has come in, a real mouthful. But what it's trying to explain is that the underlying disease mechanisms are slightly different, has a similar clinical phenotype, but what happens is that the airway epithelium does not produce multiple motile cilia, so you have an effective aplasia, or a ciliary aplasia, if you like. And there's other terminology beginning to appear. So it's probably better to start thinking about these as a group of respiratory ciliopathies, or inherited conditions of respiratory motile cilia. The prevalence has increased a lot since I've come into this field 15, 16 years ago. We used to report it about 1 in 30 to 40,000 across Northern Europe. It's now as common as 1 in 10,000 in some cohorts, particularly where there's a high degree of consanguinity. It can be more common than in cystic fibrosis. So for instance, in the highly consanguineous ethnic minority group in Bradford and Leeds, for instance, Chris O'Callaghan's group have reported that it's more than 1 in 2,500 patients in that group with PCD. And in this Volendam community in the Netherlands, it's as high as 1 in 400. So we do have pockets where it's a particular problem. We know, like CF, it's mostly inherited on a recessive pathway, but we now have recognized X-linked and dominant forms of respiratory ciliopathies. And this year we've just hit the 50 mark for our known pathogenic mutations in this group of conditions. That's for respiratory motile ciliopathies. It doesn't include the wider number of syndromic ciliopathies that may have an overlapping respiratory phenotype. There are many more mutations that account for those. In our cases that we've made a diagnosis, so we've confirmed a structural or a functional defect and confirmed a diagnosis, we can then find pathogenic mutations in about 3/4 of those cases. It's not the case to say if you went into a bronchiectasis clinic and did genetics as your first line test, your pickup rate would be much lower, sort of 15 to 20%. So although we can use genetics very effectively within a well classified cohort of these patients, if you like, it's still not a first-line test that we would go to. We would always do those other diagnostic tests, and I'll go through that today just to show you what what tests we do and what we're looking at to try and make a diagnosis. There is a common phenotype across this group of conditions, and there is a clinical spectrum of severity. The things we're seeing: otosinus disease, the chronic obstructive lung disease. In adults, of course, reduced fertility in both men and women, and of course the classic organ laterality defects. And we'll talk a little bit more about that, but that's because of the cilia within the embryonic node. I'm not going to dwell on this, but it's the sort of timeline of when people started to notice that there was something different about these patients. So it was over 100 years ago when a clinician, this guy Sievert, noticed that some patients with chronic respiratory disease had dextrocardia. And you can actually see here, most commonly the situs abnormalities are not just a single reversal of where the heart sits in the chest, but all of the organs. So you get this mirror image, situs inversus totalis. But it was Cartagena who actually gave his name to the syndrome, which you will probably have heard of, Cartagena syndrome, where you have situs, bronchiectasis, and otosinus disease. But it wasn't until the 70s that an electron microscopist, Afzelius, noticed that in fact he was getting samples from fertility clinic, noticing that some of these patients had sperm motility problems. And when he looked at the ultrastructure of the sperm tail, he noticed that compared to normals, there was absence of some of the proteins that he then began to recognize that this was a problem for the sperm motility. He and his colleagues went on to then describe real heterogeneity. So it wasn't just one particular abnormality of the cilia. So there would be different sort of defects that he picked up. And we've seen this now that we're going through gene discovery, that is a very heterogeneous condition. It was in the 80s that, or 70s and 80s, in fact, that they started to discover the early genetic mutations, and the name changed again to Primary Ciliary Dyskinesia. And as I've said, it's now becoming a much sort of wider group, you know, that we're using different terminology to be a little bit more specific. And we're seeing particularly these respiratory phenotypes associated with syndromic features such as retinitis pigmentosa, hearing loss, polydactyly, etc. Sorry, I just need to go through. I'm not sure you saw all of that, did you? Sorry, I've got 2 slide things. Anyway, let me carry on. So where are our motile cilia? As we've described, the respiratory tract is lined with multiple motile cilia on the airway, from the nose, the eustachian tubes, all the way down through the lungs. But we also have motile cilia in the brain, so in the ependymal cells. And sometimes we'll get referred patients from the fetal cardiologists who will comment on a situs or a cardiac defect, but also tell us that there is a bit of ventricular megaly. And hydrocephalus is one of the associations with ciliopathies. In the reproductive system, so in the fallopian tubes for women, and the sperm as we've described for men, so subfertility in both genders is a feature. It's not always a given though. They are not infertile, all of these patients, so you should not advise that they are. And in the embryonic node, as I've described, and I'll go on to show you, this is a slightly different type of motile cilia, but it determines laterality. And we need to have, that cilia determines the calcium flow from right to left across the embryonic node here. And that calcium flow is very important in our right-left organization. And so when you have defects of the cilia, you of course get this random, often this random organization of your internal organs. I just briefly want to talk about the axonemal structure. What we're most interested in for this purposes of this talk in the motile cilia, and you'll hear terminology such as 9+1, 9+0. This really describes these microtubular doublet pairs within the ciliary axoneme. So each individual cilia, when you take and cut in cross-section, you will see these microtubular doublet pairs and these pincers, which are the dining arms. These are ATPase units, and they confer the motility on these cilia. We have the 2 are the central doublet pair, We have radial spokes and necks-in links, which are little links between the doublet pairs here, and these all infer architectural integrity within the cilia. So it's a very highly conserved structure that's readily recognizable. And in our respiratory tract, we have these multiple motile cilia. They're very synchronized and unidirectional beat pattern, and they sweep mucus and debris and bugs up to the back of the nasopharynx, back from the nose to the nasopharynx, and drain the eustachian, the middle ear, via the eustachian tubes. We also have 9+0 motile cilia, and these are the ones I was describing in the embryonic node. So you can see there's a single one per cell. And when you don't have a central pair, that gives you a rotational motion. That's quite important for our diagnosis, as I'll go on to show you. But that's the sort of motility pattern we see in the embryonic node. We have another 9+0 structure in non-motile or sensory cilia. These, you can see, don't have dynein arms and are effectively immotile. They're called sensory cilia. You have one on the surface of most cells in the body. They waft around, and they have lots of sensory roles, if you like. We're not going to go into that today, but they're quite important. And these primary cilia are often involved in the more syndromic ciliopathies. So when you're seeing patients in clinic, the difficulty with PCD is twofold, I think. One is that the symptoms they have tend to be very common to all preschool, early primary school children. And so it's a little bit like picking the wheat from the chaff, and you have to decide why is this child with their sort of chronic runny nose and glue ear and, you know, frequent wet cough any different to the next one who actually has no underlying disorder at all. So a lot of it's in the history, and a lot of it is just recognizing some of the cardinal signs that would make you think about referring. The second thing that's difficult about these patients is they tend to be very laid back and always report feeling well, even when they're not so well. So they are quite difficult to clinically assess. And we'll go on to I'll go on to speculate why I think they do have that sort of slightly different approach. It's quite hard to get them to admit that they're feeling pretty rubbish, even when their lung function is in their boots. But just going back to the sort of key aspects of taking a history and examining these children, of our cohort of patients with a confirmed diagnosis, if you take a good history, 75% of parents will report that their child had unexplained neonatal respiratory distress. So a term infant, no evidence of meconium, no other underlying obvious conditions that, you know, comes out looking well, but ends up in the neonatal unit needing oxygen, needing CPAP, sometimes ventilated, needing antibiotics. Absolutely key question to ask whenever you see a child with chronic respiratory symptoms, because 3/4 of them will have that history. Wet productive cough. So PCD untreated in particular, parents will describe that this is daily, tends to run through the seasons, they're often well with it, don't necessarily have an intercurrent infection, another cardinal clue. They are prone to recurrent chest infections, tend to have them longer than their siblings or peers, and it's a pretty inevitable progression to bronchiectasis in the majority of patients, particularly if they're untreated. Chronic rhinitis in children, sinusitis in older children, but parents in this particular cohort, which was in North America, reported 100% of cases of PCD in their child had rhinitis from the early days of life. So pretty important. And if they've got other children, they'll know that this was a really very different to how their other children were. So if they report that early days, relentless, doesn't matter what the season, doesn't matter if they've got a cold or not got a cold. Recurrent otitis media, again, another frequent symptom in this age of child. But if you get persistent otorrhea post-surgery, so this is a rather nasty malodorous discharge, they've had grommets put in, and rather than seeing a nice clear ear canal with improved hearing. In PCD, you often get this very nasty discharge, and it can go on for weeks and months and actually cause quite a lot of distress because, as you can imagine, it's not very nice for them being at school if they've got leakage of pus from their ears. And they often have severe or persistent hearing impairment, more than you would expect with glue ear. Situs inversus, usually around 45 to 55% on, depending on the different cohorts. That tends to lead to earlier referral and diagnosis for obvious reasons, but also think about other features, syndromic ones. Is there an associated hydrocephalus? Have they got a cystic, hepatic, or renal disease history? Are there eye problems, specific forms of congenital heart disease, a history of polydactyly? All of these things that might make you think there's something else going on that's related to their cilia. All of those should prompt a referral. The sort of imaging you see, this is an absolute classic. I've really put these up because you could show lots of these, but what's important to think about if you're seeing an X-ray, obviously if you've got the situs inversus, you think that this is bound to be PCD because you can see the bilateral streaky markings that would make you think there might be airway thickening and bronchiectasis here. But if the situs and the was normal and you had these changes, you might think there's a predominance here in the middle and lower zones. And that's quite important because that is different to cystic fibrosis that tends to favor the upper zones. And some radiologists would tell you that if they were given, CT scans from a cohort of PCD patients or a cohort of CF, that they could, with about 80–90% confidence, tell you whether it was PCD or CF related because of the distribution of disease in the lungs. So you can see the situs here, the heart's on the other side. This is what would be normally your right middle lobe, here collapsed and consolidated with great dilated airways. And this is classical cylindrical bronchiectasis, but some tree and bud down here. And these changes, you probably wouldn't be in much doubt that this lady had primary ciliary dyskinesia. Other features, these are two patients from the Brompton. The one on the left is cystic fibrosis, the one on the right from a patient with primary ciliary dyskinesia. You can see in the case of CF, very tenacious mucus plug, probably quite difficult to aspirate, but also notable inflammation, very inflamed and edematous looking friable airway epithelium, in contrast to this patient with PCD who has a lot of mucopus here, usually easier to aspirate, quite liquid, and you feel you can get a good result with sucking all of this out. But notice how uninflamed this airway epithelium is, and that's not that uncommon when we do bronchoscopies on patients with PCD. And it's this sort of lack of airway inflammation that makes me think, and this is purely my observation, but it makes me think that they have blunted inflammatory responses, and that's why they come into clinic reporting that they feel really well. There is a really quite significant difference, even when lung function is down and they have this amount of infected and inflammatory material in their airways. We've talked about grommets, what you'd hope if you put in a ventilation tube, a nice clean result with improved hearing. This is the result you often get if you put a grommet in a child with PCD, and it really is very distressing to them and the family. If you're thinking about PCD and you're worried about their hearing, please do refer for us to at least try and confirm or exclude the diagnosis before you refer on for grommet surgery. And finally, nasal polyposis. So this actually is a patient of Ian Balfour-Lynn's. It's a patient who I think is post-transplant for cystic fibrosis, but it's a nice picture of a polyp. PCD is on the exclusion list of differential diagnoses if you see patients with nasal polyps. It is a feature in a small subgroup of ours, and it can be a little bit difficult to treat. So if you've excluded everything else and they're still having problems, consider primary ciliary dyskinesia as a cause. And as we've said before, the syndromic ciliopathies, there is a real overlap with these and a respiratory phenotype with abnormal ciliary structure and function. And we have patients with all of these conditions in our clinic. A significant number now of patients with retinitis pigmentosa in a respiratory phenotype. Bardet-Biedl, another fairly significant subgroup, but we have 2 or 3 with Joubert's and Sensenbrenner, and about 1 of each of these. And they are important. Not all of, we go into the Bardet-Biedl clinic, and it's only around 15% of them have a respiratory phenotype and need to come over to us to have a sort of shared care arrangement to look after their airway disease. But if you're seeing patients with a diagnosis like this with a respiratory phenotype, please do refer. They are rare, but they will pop up in clinics every now and again. And it's important that they come into the service both for their underlying condition, but also for their respiratory ciliopathy. So about 5-6 years ago, we decided it would be useful to put together a predictive score so that people seeing patients like this in clinic could make an assessment and make a determination, were they different from the normal preschool child with these symptoms, and should they refer them up. This is called the Picca score, and it's really only to be applied in patients that have a chronic daily wet cough. So if they don't have that, the Picca is not really designed for that patient. But if they do, then apply these questions. You don't necessarily need this piece of paper, but it's quite a good way of just, you know, having a mental checklist to go through these. So we talked about these first 3 pertain to neonatal respiratory distress. So was the baby born full term? Did they experience breathing problems in the neonatal period? And did they go to a neonatal intensive care unit for oxygen, CPAP, whatever? That gives you a combined 6 marks. And you can see down the bottom here that you need 5 points to lead you to the referral process. So those 3 alone should prompt that. Do they have a situs abnormality? I think always, even if it's a standalone, nothing else, even though it's only 4 points, I think it's worth referring those, particularly if they're small and it's difficult to know whether they're going to develop those chronic symptoms quite so clearly. Did they have a congenital heart defect, perennial rhinitis, as we discussed, and chronic ear problems? So as I say, you don't need this piece of paper, but it's quite a useful checklist to just have to help aid referral. What do you do when you're thinking, okay, they score 6 or 7, I need to refer? Well, the Primary Ciliary Dyskinesia diagnostics and management now is a fully commissioned service here in England. The red centres with the red arrows here are the 3 diagnostic and management services. So here in London, you'll refer to the Brompton, and we serve East Anglia all the way down southeast plus London. Southampton, if you live in the southwest, goes up to Oxford and all the way down. And Leicester, which is here, does the Midlands and North. And then there's a further management centre that was added in 2012 up in Leeds and Bradford because of the high population of PCD up there. So refer into these pathways. It's free to all referrers, and please do make use of it. When they get to us, what do we do? Well, obviously a clinical assessment, applying that mental score of the Picca that I've just described. And assuming we're fairly convinced, we will take them through the diagnostic pathway. And this is Tom, who actually does have PCD. He's now about 15, so it's quite interesting to see him. But our screening tests now, we no longer do any saccharin or charcoal-based screening tests. They were never reliable or particularly safe in children. But we do use nasal nitric oxide as a measurement of ciliary function. We think actually we don't really know what the relationship is, but it's fairly sensitive and specific for screening tests for respiratory ciliopathies. It's easy and it's done in real time in clinic. So this is one of our clinic rooms. He's holding a soft olive up to his nose. And you can see here on the right, it gives us a dual readout. I hope you can see that. The pink line is carbon dioxide. That means he's able to hold his breath successfully. And the green line, which I'm going to trace for you because it's probably not that clear, is fairly flat line at around 50. That's very low result. Normal is over 200 to 250 parts per billion. So if we've got less than that, it's convincing, along with a clinical history, that this is likely to be primary ciliary dyskinesia. We'd go forward to do a brushing using just a simple cytology brush here. And then what we're interested in measuring is the beat pattern and frequency, so the functional test, the ultrastructure using electron microscopy, and then from the primary nasal brushing, we will often send off to our cell culture lab so that we can regenerate ciliated epithelium and rerun this diagnostic panel again. And that's because often, particularly in children with frequent chronic viral infections, these primary samples are not always that healthy and we can't get a complete set of diagnostics. So the cell culture is an excellent backup tool for doing that. What are we looking at? Well, you can see, let me get both of these videos running. We're looking side and top views to see that we have a nice well-ciliated sample, but we've got a nice recovery and power stroke, so a normal beat frequency. And I think you can see here, hopefully, debris and mucus being shifted along. So we can see mucociliary clearance. And we want to see whether we have that normal stroke, whether the cilia looks stiff, whether they're immotile, there's the odd staggered beats, are they circling? And of course, down the bottom, there are some other strange features that I'm going to show you that are associated with the wider group of respiratory ciliopathies. So let me just go on to show you what we then do. We take that sample and fix it, and we use transmission electron microscopy to look at the ultrastructural components, so the different proteins that we know can be impacted by the genetic mutations. So the dynein arms we've talked about, outer and inner, the nexin links, which are these little links between the doublet pairs, the central microtubular pair, the radial spokes, etc. This is a normal electron micrograph. So you can see very nicely that 9+2 arrangement, clarity of the dynein arms, you can see the radial spokes and the central pair. So we're looking to see when proteins are missing from that. So I'm just going to run through, this is a classic case of PCD. This is actually the child you saw doing his nasal nitric oxide. Just in case, if you look close, you can see that the film is just jittering, but these cilia are completely static. Not difficult to make the diagnosis in this patient. And when you look at this, he's got very nice 9+2 radial spokes, but these figure of 8s have lost their pincers, they've lost their dynein arms. So we can confirm that diagnosis based on those two tests. We don't need genetic testing, although we always go on to do that. He has a confirmed class 1 ultrastructural defect diagnosed using electron microscopy. But we have other beat patterns that are also abnormal. So in these two samples, you can see from the top view, they're not linear at all. They're both swirling around, circular. So the same sort of rotational beat pattern that we saw in the, I described in the embryonic node. So you would assume this is going to be a central pair defect. And sure enough, when you go to your electron micrograph, you can see that there's this intermittent loss of the central pair, and you'll see it in some of the cross sections. So this is the normal, you'd expect that contiguous appearance to the central pair in the longitudinal section. A different mutation, a different beat pattern, a common clinical phenotype. Again, this one here, I think you can see this video is running. There is residual movement, but it's incredibly stiff. There's not much mucociliary clearance going on, very abnormal, not completely static. This is due to the microtubular disorganization and inner dynein arm defect, complex mouthful there. It basically means the absence of the inner dynein arms mean the radial spoke head proteins can't attach properly and you get disarrangement, so they look scrambled. And again, these are different mutations, and in fact the mutations that cause this sort of abnormality tend to confirm more severe lung disease. So we're starting to recognize geno-pheno correlations in these this heterogeneous group. This is not a patient with primary ciliary dyskinesia, but I wanted to show you how often we're picking up secondary ciliary dyskinesia, so the impact of other inflammatory airway diseases. This is a child with quite significant asthma. When she first came to us, had rhinitis, had a chronic wet cough. She did tend to wheeze. We did the whole workup. She was very atopic, was not being treated for her asthma. And you could see her cilia just look really stuck together. You can see they're sort of trying to do a normal beat pattern. When we then looked at her cilia under the electron microscope, you could see why they're stuck together. They're clumped with these funny little interconnections. This child has asthma, and when she got on proper treatment, this completely reversed, and she had a normal beat pattern, and these interconnections went. So this was almost like a secondary impact on her cilia, not a genetic underlying condition. And then finally, I've talked a little bit today about the patients with syndromes such as Bardet-Biedl. This actually is a patient with Sensenbrenner syndrome, so a primary ciliopathy. And they have these very odd cilia, and we've got quite a group of these now across different, and you can see here these very long whip-like cilia, so twice the length of normal cilia, and lots of bulbous tips here. So these little sort of drumstick appearances. They're moving, but they're dyskinetic, and they have poor airway clearance. In the electron microscope, you can see here the normal sort of ciliary axonemal structure, but these huge sort of bulbous areas with inclusion bodies. And we think this is a transport disorder. So we've got quite a group of these. They do need the same sort of management with physio and treatment of infections. What do we do with the results we have? Well, we tend to end up with three groups: the definitive positive, so as I've described, a hallmark or class 1 ciliary ultrastructural defect, or a pathogenic biallelic mutation confirms the diagnosis. They should go straight into the management service here at the Brompton or any of the other local services. The highly likely, so very good history, positive screening test, often highly abnormal and consistently abnormal beat pattern and frequency, but maybe they've got normal electron microscopy results and we haven't found a gene, but we're very suspicious, so we treat as PCD, keep them in the management service and apply additional testing. Or extremely unlikely because of have none of these other things we've talked about, so we either discharge or investigate for another diagnosis. So what are we going to do with that middle group? We're worried about them. We've undertaken quite a lot of research here at the Brompton over the last 15 years, particularly to look for new and improved or more advanced diagnostic tools. And I just wanted to talk about that. We've developed immunofluorescent antibody staining as a clinical tool for PCD, and we've devised as a research tool 3D electron tomography, so it's more like a sort of form of super resolution imaging, and we've worked very hard with and collaborated on genotyping and gene discovery. And these three additional tests, which are largely research funded until this year, have actually helped confirm around 15 to 20% of our diagnoses across the PCD cohort. And they've done that in driving gene discovery and in confirming the downstream impact of novel genes, for instance. We're now moving into artificial intelligence, and I'll just talk a little bit about that at the end. But the take-home message is, if you're concerned about the history, if there are some of the tests looking a little bit abnormal, you have to keep those patients in the clinic and continue to pursue a diagnosis, because we do have a massive reduction since we've had these three tools in particular in our difficult caseload, which have had confirmed diagnoses as a result. Very briefly, immunofluorescence. This is just a brilliant thing to have done, because of course it's a technique that most diagnostic labs would recognize and undertake for a whole raft of different conditions. So it's all about just validating it for its use in primary ciliary dyskinesia. It's very easy. From the primary brushing, you smear slides and dry those. And I'm not going to go through the whole technique because we don't have time, but we developed from a group of researchers interested in developing antibodies for the different proteins we're really interested in looking at. So as you can see here, the ones we've talked about: outer dining arm, nexin links, inner dining arm, radial spoke head proteins. But we've also now got IFT88, which are the ones that we use for those odd bulbous tips with the inclusion bodies, DNH11, which is an outer dining arm protein, but it's one we can't pick up on electron microscopy. So having a decent panel has been a really good adjunct to our diagnostic pathway. Just so finally, before we have a look at some images, acetylated tubulin is the key. You have to prove that you've got cilia on the cell before you go staining with these antibodies. Otherwise, absence of staining might just mean you have a false positive, if you like, because in fact there were no cilia on the cell. So let me just show you these. So this is a normal healthy control. You can see here we've seen that on the EM all the proteins are exactly where they should be, and we're going to use stains for the outer dining arm. See if I can get my cursor, sorry, and the inner dining arm proteins, and for that we use DNAH5 and DNALI1. When you do the staining, the nucleus stains up in blue, so using DAPI for that. The acetylated tubulin that I talked about before, so we can see that it stains very nicely in green, and you can see it's a nicely ciliated cell, so it's appropriate for a diagnostic IF staining. And then using these two antibodies, H5 and Li1, for outer and inner dining arm, you can see it stains very nicely in red. So the protein is there as you would expect from this being a normal healthy control. When you merge these two, you get orange, and that's what you want. That's a normal result. The protein is staining nicely. This patient, the one as we had before, absence of outer and inner dining arms, you can see they're missing. Same stains, absence of staining completely. And so when you merge, all you can see is the acetylated tubulin. So this confirms what we've seen here on the electron micrograph. And what's good about that is it's quick, it's cheap, and we can use much less sample, if you like. So you need many fewer cells to get a result from immunofluorescence than you do from electron microscopy. And moving forward now, we have antibodies that we can detect protein localization defects that we can't pick up with EM, and that's the key to this. So it really adds to our ability to diagnose the more difficult cases. This was validated here in the laboratory here about 3 years ago, and it's now rolled out across the national service. So all of the diagnostic labs have this technique available now. And then very quickly, electron tomography. This is original research from this laboratory, actually. We were very lucky. We had someone come and cover some maternity leave for us who had an interest in 3D tomography of cardiac myocytes. And when he came to do the role in our clinical laboratory, he thought that the electron microscopy of cilia really lent itself to more super resolution imaging to look at subtle defects. And what we're aiming to do is basically, if you consider this a normal two-dimensional electron micrograph, like a shadow figure, if you like, with 3D tomography, we're looking to see how all those structures within the shadow make up the outline, so we can see in much more detail. And the beauty of it for us is we use our own electron microscope, which is tomography enabled, and we use the same brushing sample from the primary sample that we did. So we've stored that, and we can use it to generate tomograms. And the way we do that is we take a sample here, and with the microscope, we apply a tilt series of images. So at every 1 degree, the microscope is taking an image. We switch it around 90 degrees, and then we do another one iteration of images on a tilt series. And then we stack them up using manual and computing models to do that. So these grids have little gold granules in them, and you can line them up so that there's a lot of iterations. This is why it's a research tool at the moment, because it is quite lengthy. And then using modeling and surface reconstruction programs, you can generate very nice three-dimensional models of sections of the cilia, or indeed of the whole cilia. So I just want to show you one particular case where this was very influential, both in confirming the downstream impact of disease, you know, candidate genes, if you like, and hiding was a really difficult one. It's quite a heterogeneous, sort of large loci, if you like, and you've got this rather odd, are they both working here? Sorry, I've got two screens, which is why I keep looking to the right. But you can sort of see this is slightly dyskinetic. At first view, you think there's good ciliary motility, but when you look from the top, there's this funny twisting, circling motion. So we thought, this must be a central pair defect. We were seeing this across several with this possible hidden mutation. And we are working with a group at UCL and in Münster in Germany who had similar cases. And you can see this is our patient with PCD, has a normal central pair, which we don't expect with that odd beat pattern compared to the healthy control. So both the central pair microtubules were there and they look very healthy. When we use the tomogram, and this is the sort of structure detail that you can get, this is one of the microtubule doublet pairs. So you can see they're here, but you get all the associated detail. There was a big gap here. This is the C2b protein that you can't pick up on the electron micrograph. And compared to the healthy control, you can see where the normal protein should sit. And that actually was quite instrumental in helping confirm the pathogenicity of these mutations, but also explaining why we were seeing this circular motion. So it was an impact on one of the proteins in the central pair. And then finally, artificial intelligence. The structure of the ciliary axoneme is highly conserved. It's one of the most highly conserved structures actually in the human body. I think it's gone all the way through green algae, it's in fish and mammalian species, and it stayed like that across the millennia. So it really lends itself to artificial intelligence, sort of, you know, pattern recognition, if you like. We were fortunate enough to get an NIHR Invention for Innovation grant, and we partnered up with a company called Cosmonio, who have this platform called NU. And this is an interactive deep learning. So it's not the same, I don't know what you know about artificial intelligence. I certainly knew very little, but the majority of artificial learning tools come out of, artificial intelligence learning diagnostic tools come out of putting data in, masses and masses of data in a sort of black box model, and the machine and a data analyst start to look at patterns. And then the information comes out and they think, well, that looks quite useful and it sort of makes sense. Let's put more data in and see if we can refine it. The new system is interactive, so it's on the job, training in real time, and rather than it being a data analyst, it's a clinical expert. So we have a research assistant who has over a decade of experience in PCD diagnostics, and she's now running this program, and it's proving quite exciting. We wanted to focus on electron microscopy and how we could improve the speed and accuracy and take away the subjectivity, if you like. See if I can move it on. So what we're doing is, this is a scanning EM of the airway surface epithelium. We fix that, we process it for electron microscopy, but we want the machine to start learning two things. Want it to detect what's a healthy cross-section that we can use for diagnostics, and then we want to move on to classify normal from abnormal, and then to classify individual structures such as doublet pairs or central microtubular pairs. So the aim of this project was to detect normal cilia, detect abnormal cilia, and then classify what was normal or abnormal about them. So we've been training it to recognize doublet pairs, the central complex, the outer dining arms, the inner dining arms, the radial spokes, and the Nexin links. And this one's really interesting because they're actually quite hard to see by the human eye using electron microscopy. And what we do is we have a learner, which looks like this sort of Star Wars machine. This is the sort of brain of the AI workstation, if you like, and we have a tablet. We use Microsoft Surface Pro. This is the new that we use for the interactive on-site training, and you'll see it gets presented with these patient samples. And if I can get this video to work, this is Andrea, who is teaching it how to detect usable cilia for diagnostics. So here she's going, yellow, this is a good one. And in blue, we can still use this even if it's slightly tilted. I don't know if you can see that, but it says tilted cilia. So she does this for hundreds and hundreds and hundreds of cilia per hour. So thousands of these have gone in now to train the system. The system then exports these annotated boxes and classifies them into useless, which are the yellow, normal or abnormal. So useless means you can't use that for diagnosis. It's too fuzzy, it's compound, it's unhealthy, whatever it is. Normal, so doesn't have a defect that we would recognize as PCD. Abnormal, there's a missing outer dining arm, etc. And that's been incredibly successful. So it's become very accurate at doing that very quickly, actually, as we expected because of this highly conserved nature. So it will tell us a good cross-section. It will tell us if one is tilted, but we can still use, because there's a central pair we can see. We can see 5 out of the 9 outer dining arms, 4 of the inner dining arms. So an expert that is used to looking at these would use this to contribute to a diagnostic result, but it is highly subjective because there's a clear, there's a fuzzy one. We wanted the machine learning tool to get to not work, to eliminate the subjectivity, if you like. And Andrea loves to use this dog versus mop model because, you look at this and you can see it's highly subjective in terms of determining which is a mop and which is a dog. And this is the problem you have with machine learning. You need to put more and more data in to train it to recognize those subtle things and eliminate the subjectivity. Where are we at so far? Well, our detection of cilia has gone really well. So it's very good, the new, at recognizing these figures are what the data analysts that we work with ask us to, or they come in and they measure the accuracy of the machine learning tool. I don't quite understand what this means, but what I do know is you have to be above 0.75 for it to be accurate. So detection, it worked very well. Detection of individual structures within the axoneme, also matching already. And when we looked at the central pair, you can see highly accurate at that. This data is about 3-4 months old now. We haven't got back together since the pandemic, but Andrea is still working on this, and I understand these figures have got even higher since she's been doing that. We're due to validate this now alongside the clinical pathway, and again, that was just starting in the 2 months before the pandemic stopped our diagnostic process, and there was 100% match up with the clinical experts and the new system, which was really interesting actually. We'd done about 20 cases and there was always 100% agreement, blinded, between experts and machine. So just to finish off, and then hopefully there's some time for questions. The prevalence of PCD is probably even higher than currently reported. I think the reason we can claim that is that we expect about a 10 to 15% positive return on our diagnostics. That's what we have in the pediatric clinic. But we also discuss adult cases every month at our MDT, and they're getting about 50 to 75% positive return rate on all of the cases presented. That means that in these big bronchiectasis clinics, there are probably plenty of patients sitting around with undiagnosed PCD. So it's about thinking about it, trying to get people to refer up. Wider circulation of Picca as a screening tool, I think that would be useful. I think to put it out in archives, for instance, and maybe the BMJ. You don't need it to hand, but it just is a really good prompt to have those questions in your head. From a diagnostic team perspective, for us, it's about doing the basics well. You know, we can make a diagnosis very easily in 70 to 75% of the cases, but then we have that 20-25% that need those additional tests, need that extra scrutiny, and, you know, us revisiting it until we can pin down and confirm or exclude a diagnosis. And that's really important to do that, I think. It does take research and it takes collaboration. And I think one of the keys over the last decade in particular is we meet once or twice a year with our national groups, but also on the with the European consortia, and we all bring our difficult cases. And it's really interesting if you sort of say, we've seen this, and someone goes, oh, we've had 2 of those. And then you start working together on that collaboration. And we probably had about 6 or 7 different publications which have brought shared cases together that have led to gene discovery and have you know, advanced diagnostics for patients with this condition. So I'm going to stop there, and I'm very happy to take any questions. There's no chat. I've just sort of rattled on through that, so there's nothing on the chat line, but if anyone wants to just ask a question. No questions. Okay, so Claudine, do we have PCD as a secondary problem due to chronic exposure to pollutants or other such toxic inhalants? So we don't have primary ciliary dyskinesia as a secondary problem, but secondary cilia related problems are very interesting, I think. You know, what is the impact of pollution, other forms of chronic inflammatory or infective lung disease on our cilia? I think that definitely is something we need to explore. We are interested in doing that. In fact, we've just had another grant submission to look at ciliary function in a whole range of chronic inflammatory lung diseases, because that one I showed you on the patient with asthma, we see also abnormal ciliary function in cystic fibrosis, which I don't think is primary to cystic fibrosis, but more to the environment in the airways as a result of that. So it's not a primary problem with pollution. So Saji, does cigarette smoke affect? It certainly affects ciliary motility, yes. It's one of the first things we advise all our teenagers and adults: do not smoke. It will reduce your ciliary function even more. Oh, sorry, yeah, not primary. So yeah, I don't know. Have I answered those, Claudine? Did I answer that adequately? Cool. Any other questions? No? We happy? Shall I stop sharing my screen?
Mm-hmm. Brilliant. Well, I think then it just remains for us to say a huge thank you to you, Claire. Much appreciated. We really appreciate people giving their time to do this. So thank you. And that was totally fascinating. So I think we will put the recording link up on the shared drive this afternoon, just to remind people. Obviously, you can share that with colleagues that are not able to join the 8:30 session. We do understand it's a tricky time. And that link is available from your paediatric directorate or postgraduate teams. And just to remind people then that we will be back next week at the same time, and next week Caroline Foster will be talking to us about HIV in children. So again, on behalf of everyone, just a huge thank you to you, Claire, and we'll see everyone next week.
No, you're welcome. Thanks very much, everybody.